Hi, everyone. Welcome to the Chief Resident Incubator Google Hangout with Dr. Rob Orman, sponsored by Dynamed. We're really excited today to have Dr. Rob Orman. He is a community EM physician, the former editor of EMRAP, a co-producer of Essentials Emergency Medicine, and creator and editor-in-chief of ERCast. Today, we'll be talking about community medicine and non-traditional career paths towards education. Take it away, Rob.
All right. Hey, Chief Residents in the Incubator. How you guys doing? It's funny. You guys can't see this if you're listening to it on SoundCloud, but there's a cat with his tail up in Will's camera, and the cat's anus is right on the camera.
I promise. This wasn't my idea.
Such a fitting start. Such a fitting start. That's Will at George Washington, D.C., doing a sports medicine fellowship in Salt Lake City next year. So if anybody's in Salt Lake City, they can, and listening to this, just bring that up to Will at some time, because it was a great moment, totally spontaneous. Thank you for that, Will.
I apologize.
No, what? Apologize? That was awesome. That was great. Hey, all right. So you guys sent me, or someone sent me, some questions beforehand, and I'm going to read the question. And if someone who sent in the question is in this crew, I know we don't have everybody in the incubator in this crew. I'm going to ask you about the question, and then we'll talk about it. So the first question was, talk about your pre and post shift routine. Who asked this question? Nobody in the room. All right. Well, here we go. Then I'll run through this quickly. So my pre-shift routine. In the morning, if I'm able to, if I have time or get up in time, I try to meditate, try to get my mind settled. An hour before the shift, take a shower. 45 minutes before the shift, I eat. Preferably something high in protein so I don't get hungry too early. And then 30 minutes before the shift, I leave the house. And it depends where I'm working. I mean, some places where I work are an hour away. I'm going next week to work at a place that's like a 2.5-hour drive over a mountain pass. I got to stay there, etc. So it's like there's permutations to this. But let's just say the hospital is 15, 20 minutes away. 30 minutes before, I'll leave for the shift, so I've got some buffer time. And when I'm en route to the hospital, I will listen to something clinical, such as a podcast, and I find that puts me in the mindset for like sharp clinical focus. My go-to podcast that I listen to en route to a shift is EMRAP. And so many times I have heard something on that I've been able to apply directly to what I see that day. When I arrive, I put on some scrubs. Sometimes I actually have to wear scrubs depending on what the hospital has. Just know that not every hospital is going to have scrubs. Not going to have some nice things. You might have to bring your own stuff. So, but if they have scrubs, which is nice, I'll put them on. And then before I go into the ED, I check the weather pattern in my mind. Meaning, like, is it like kind of frenetic? Is it calm? Is it scattered? Is it focused? And if it's scattered, and you know what it feels like when you kind of got monkey mind and you're just going pew, 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 pew all over the place. If it's scattered, then I take a few moments, take a few breaths to try to focus, try to center, try to calm my mind. Now it's about 10 minutes before the shift starts. I go to my computer station, log into my EMR, log into Dragon, and sometimes you get a Dragon on a computer that's not accustomed to your voice or hasn't been trained to your voice, and you have to do the training all over again. You don't want to do that when you're actually in your shift. Then I wipe down my workstation, and it's very controversial. You get a lot of shit when you wipe down your, oh, can I swear on this? Is swearing okay? Lang, you going to beat me out with swearing? Swearing's okay?
You can do whatever you want.
Okay, good. All right. So I wipe down my workstation with the wipes that have the picture of don't wipe the baby's butt with this wipe. Like those, the Cavicide or whatever. So I wipe everything down. We're wearing gloves. And you asked me what I do before a shift, so I'm getting very specific. I wear gloves, wiping it down. And then for the first 10 minutes there, I'm actually on my workstation with my gloves. So I'm letting that Cavicide evaporate. And I wipe down the phone, all that business. And you get a lot of grief for that thing. People like, oh, you're germaphobe. It's like, well, dude, who do you think is going to get screwed at the beginning of the zombie apocalypse? It's us in the ED. We're not going to be the people on the TV show that are the survivors. Trust me. We're like the second zombies after the first zombie in the ED bites us. Anyway, I wipe down my workstation. Then I talk to the charge nurse. I say, you know, what's happening? Usually they come to me and say, here's what's happening. But if I don't get that, I'll talk to them what's happening, such as, are we full on beds? Are we going to need to be transferring patients? How many patients are we holding in the ED? And what's the roadmap for the beginning of my shift? Like, what patients have been put into my rooms? So that's the beginning of the shift. And before I go on to post shift, any questions, thoughts, incubation on pre-shift? Okay.
Yeah, I actually, Rob, sorry to interrupt. I got a quick question. I'm Derek. I'm a fourth year up at Brigham and MGH.
This is Derek, he's a PGY 40, who's did anesthesia pre-emergency medicine residency, now is in his final year of emergency medicine and is going on to be an education fellow next year. Well done.
Thanks. I'm just curious who gave you that advice to do a mental check before you go into shift. I could probably start using that myself. So now I'll give you the credit, but I'm kind of wondering where you got that in the first place. If it was someone within EM or just another specialty or something outside of medicine.
No, I tell you, it was done out of necessity because I find that some shifts I'm on, and it's just every interaction is just 1, 2, 3. I got it, and it's almost like I've taken some kind of a clarity drug, and I can see the path of every patient. All the dispos are fast. And then some shifts, it's just like I'm walking through mud, you know, I can't get things done and all this. And I guarantee it's not the patients. It's not, oh, wow, I just had a really odd shift where all of the patients were difficult to dispo. It's totally me. And as I went through, you know, many years of doing this, I thought, okay, some days I'm on, some days I'm off, just like any athlete, just like anybody who does any kind of job. You've got focus some days, you don't have focus some days. So I just check on what my mind feels like before then. And actually listening to a podcast is part of that ritual. It's part of getting into that right mindset and kind of turning on the clinical brain and turning off the the bike ride brain or the hanging out or the podcasting, because it's like it's a totally different mindset.
I actually had another question for you, Rob.
Yeah.
It's kind of along the lines of, this is Will, by the way, the aforementioned alleged
Yes, this is Will. He's a chief resident at George Washington in DC, and next year he will be in Salt Lake City for his sports medicine fellowship.
Thank you for that introduction. The part of the mindset that you were talking about pre-shift, I'm thinking now during the shift itself, I think everybody's had that crazy code or that really nasty patient conflict that's really kind of just upset your mojo in terms of like your flow, like you're saying, everything's clicking, 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 and then all of a sudden you get this nasty code or you get this really bad personal interrelationship, whether or not it's with another provider or whether or not it's with the patient. What do you do to kind of help reset yourself? Because I feel like my mind is just all over the place after something like that.
Man, it's a great question. It's a great question to be asking as you're about to jump into attendinghood. That because those things do happen, right? You run a code, it's horrible, and a young patient dies, and now you need to go see an ankle sprain,
right?
All the time. I mean, the last situation I had like that, somebody needed a med refill.
And they're like yelling at you because you took forever to get to them, and you're like, I'm sorry,
Right. And so a couple of things on that. Let's just talk about the code or the critical patient. And then you have to go through, then you've got to go to something that what you would think is mundane. Of course, that person has their day going and they want to, get their day moving. Whereas, your way you're seeing it, okay, somebody just died in this code and now I've got to do this refill. And that, which is, a fortunate or unfortunate part of the job, that there's so much variety in the intensity of stuff we see. So after a situation like that, I'll take a moment and just think about what happened and try to and reframe. And I don't know how the switch in the mind works, but talk myself through the process of, I don't need to bring, and I shouldn't bring any of the baggage that I have right now into this next patient interaction. And sometimes it's like you got to fake it. You can't not carry that monkey on your back because, you know, a consultant was just such a horrendous ass to you on the phone, or you were to them. You know, who's to say? But that kind of negative mentality, you know, will totally poison the next relationship. So it's to take a moment and just reset. I can't tell you how to reset, and I don't know exactly how I reset, except I think in my mind I need to reset, and it's just a little bit of time. You know, that dust needs to settle. It's kind of like a sed rate. That's why that's a lab that takes such a long time. These things need to settle, man. The sedimentation rate, it needs to calm down. You know, have a drink of water, do something that just takes your mind out. If you need to walk outside, just something to jar your mind. Eat an apple, have some hot tea. I don't know. Right. The negative interaction, I think, for me personally, Will, is actually harder to get rid of the sour taste than the code. I think that we're actually very good at switching from critical patient to non-critical patient, because you almost chuckle inside, like, oh, you know, okay, I'll go see this ankle sprain. That's totally cool. In fact, yeah. And when there's that negative interaction, I will try to beforehand just kind of talk it out with whoever might be there, whether it's a nurse, whether it's another doc, and not really bitch or commiserate, but just kind of talk through the situation. You know, what was going on, what were they getting at? There was I had a podcast, I think it was the last one I did, on dealing with difficult consultants. And, you know, a lot of it is just kind of the psychology of manipulating that conversation where you are kind of blending with the consultant, and you say, all right, well, what are the things we can agree on? We can agree this is a super sick patient, and, you know, and they're going to be difficult to dispose. So what do you think is the next best step? And, you know, that's not the answer to the question you're asking, but that kind of preempts the sour feeling to, like, you know, F you. Well, F you. Okay, slamming the phone. I'm done. So I don't have a specific tactic except take a moment, take some time, I guess these are specific, talk to somebody, but not necessarily to bitch about it. Right. Because when you do that, you dig deeper. You totally want to. You go home to your spouse, your SO, or call your work buddy, your work on the way home. It's like, can you believe this nonsense? Oh my God. You know what he said to me? The gall.
Thank you. That was very helpful. Yeah. Taking some
well, I had a really helpful fourth year when I was a second year who just said these simple words: go take a walk. She wasn't telling me to take a walk, but she just told me that was her way of dealing with things. She physically leaves the department at least once every shift, particularly after a hard interaction. So when she walks back in, it's almost like she convinces herself that she's starting the shift over again. Dr. Erica Chow is her name. She's faculty down at Emory. And I don't know, I've done the same thing. I tell people that. I find it helpful. It works for me. I don't know if it'll be the same for you, but.
I've definitely taken a couple of steps outside the Ambo Bay, and then you kind of see the regular passerby walking by the ER, and then you realize that it's a completely different world out there. You know, the sun's out, birds are chirping, and, you know,
you gotta
things are normal again. It's weird.
When you do that, like, really dedicate a few minutes to it, to just settle. And this is not a joke what I'm about to tell you, and we're still trying to figure out where to do it. One of the EDs where I work, we're trying to figure out where we can hang a punching bag and just, like, take kinetic energy and just, go Incredible Hulk on this thing. And, you know, it's just the real. I'd like to say that we're all these refined, aristocrats, but, you know, when our amygdala is in full rage mode, sometimes, let's see, what does it say? Punching bags in the psych pods? I'm moving to Oregon. No, it's not in the psych pod. We're going to put it in, like, a back office or somewhere. Hang on a sec. I'm gonna pause. There's some barking dogs. I don't want them to get in on the audio. Hang on a sec.
Wish you guys could see this. Hold on.
I love it because what Rob says is so true, because I've definitely run a code, and after the code, I had to go back to a lac repair. And when you go back, I mentally don't, I think that I've left that code and I'm ready for this laceration repair, but you can see yourself still, like a fine tremor in your arm as you're trying to do that repair, just because you kind of put that aside and have blocked it away, but physically your body's still feeling it. So love that comment. For
sure. Like that's what I'm most worried about with being an attending, because like when I'm coming back from a nasty code, like it's not just the patients on my service, it's the entire flow of the department too, and trying to catch up to that and trying to regain my footing after like a 2-hour code or something like that is something that I'm really worried about.
That refocus word, or that refocus skill, is something to, well, I would say this: the fact that you're even asking the question puts you way ahead of the game, like decades ahead in your career, because most people don't even think about it. They'll maybe develop skills or kind of get hardened to it or burnt to a crisp. But the fact that you're thinking, okay, how do I reset, tells me that you're going to figure out a way to reset or try something. And you know what? Let's just be honest. You're still going to carry some of it with you, right? You're going to be thinking at the end of the shift, oh my God, that is just such a toxic personality. Of course, the swear words I'm not going to say, but that's such a toxic personality I had to deal with. Why do they have to be like that? It must be so horrible for their spouse. It's like so horrible for their spouse at home, because they probably go home and kick the dog, and you can't not take that with you. All right. So, well, we could talk about this one for a long time, because that, and you know what? If you want to talk about it more, man, I mean, I'll give you my email, or we can back. It's, nobody has the one answer. We were just talking with the performance coach, Jason Brooks, about a month ago. And, he's giving a bunch of different skills. Like, you've got your reset word, like your keyword, level down, level down, level down. That's mine. It's like, I don't know if that's going to be yours.
I'm taking it.
We're still talking pre-shift. We've gotten into the shift. Oh, pre-shift before a night shift. Let's talk about that for a minute. So that's night shifts, believe it or not, become even worse as you get older. And what I do is, if I have an 11 p.m. night shift, at 4:30, I'll take 10 milligrams of Ambien, with the idea that I want it out of my system, and I'll sleep for like a couple hours and wake up, have some dinner, chill out, and then go into night shift. Taking it any later than that, then you're just like a little bit slow as you start, and you want to be totally sharp on. And that's just, years of doing it, figuring out what's the dose, what's the timing. For the first couple years of my practice, I didn't even know about Ambien. I didn't even know if it existed. Maybe it did, but I worked almost all nights and didn't have any kind of assist, and I would work 4 nights in a row. And by the last night, I would sleep like maybe an hour before each night shift. So by that last night, I was a huge bastard. And if there's any way that could be a positive thing, it wasn't that. It was just, oh, it was bad. There's questions coming up that I'm not seeing on my board. Is there a chat that I can pull up? Oh, there we go. Let's see. Oh, okay. That was from Derek. That was the question of where that idea came from. All right. Any other questions before we get on to the post shift? Okay, excellent. So post shift, after day shift, if the family's wrestling about, when I come home, there's like this idea of, like the family and the kids running, like everybody's so excited to see you and all that. When I come home, I don't want to talk to anybody. I'm not in that, I haven't switched to home mode. So I just need like a few minutes to myself to kind of just mill about or put things away or just chill until my brain's transitioned from hospital mode to like fully present at home mode. Then I hang out with the family, do whatever. After a swing shift or a night shift, I listen to a mindless not necessarily mindless, but at least non-medical podcasts on the way home. Usually something conversational to stay awake, something I don't have to think about, something that if I'm not paying attention, I don't have to worry and go back. When I get home, I have a snack, sometimes cereal, usually like Raisin Bran or Frosted Mini Wheats from Trader Joe's, if you want to go that specific. I'll watch some Netflix, sometimes watch too much. Sometimes I hope my wife doesn't listen to this, like 5 hours of Netflix when I get home from a shift, just to chill out the mind. And then I'll go to bed and I'll read till I'm sleepy, and then put on an eye mask, which has been a huge, huge thing. Having an eye mask, sleeping after a shift, like a swing shift or night shift, even if the room is dark, unless you have like a vault where you sleep, just no light at all. I think the one I use is like a Bucky eye mask or something. It's got a little hollow where the eyeball is, so it doesn't push in your eyeball. That's been really nice, so that the light doesn't wake you up. And yeah, pretty similar post night shift. It's kind of contra to what I would recommend. Or what I tell my kids, like, you shouldn't have blue light in your eyes before you try to go to sleep. But I've never denied that I'm a tremendous hypocrite. So that's the post shift ritual. Sometimes if it's light out or warm out, I go on a bike ride. But usually I honestly find that after a shift, and it's always been this way, I'm so tapped that doing really vigorous exercise, I find it challenging. And I find that pre-shift as well. I used to train before a shift, like going like a 4-hour bike ride or something, really intense. And then for the shift, it was just, I didn't have the mental acuity. And so now I'll do something super light, or not intense or not endurance type exercise before a shift.
What about your work? What do you bring home with you, and what do you leave at the hospital? Like charting, you mentioned Dragon. All your charting is done. You leave. You stay till it's done.
It depends on the hospital, and it also depends on how good the EMR is, or like I'd say like how less horrible the EMR is. So they're all varying degrees of badness. Some of the hospitals I work at, I'm able to access the EMR at home, and I will review my charts and then sign them from home. I used to do a lot of actual charting from home, but now I try to get the bulk of the charting done while I'm at the hospital. So if I'm doing anything at home, it's like it's reviewing and signing. And I mean, if I'm too tired, then yes, I'll go home and do it. But that's rare. I try to get it done while I'm there. And one of the reasons I do that is for QA purposes. I don't know if QA is the right way to say it, but I try to finish a chart before a patient's discharged, frankly. And people say, like the patient, it's going to be low for patient flow, and it's going to be bad. Like, you're going to be charting when you should be seeing patients. Like, I feel like that is an essential part of being conscientious about what's going on with the patient. Like Ruben Strayer has these rules that he sets for himself, that before patient's discharge, he reviews all the labs, or he does X, Y, and Z. And that's essentially what documenting is. All right, I'm going through this. I'm looking at the vital signs. I'm looking at the labs, and looking at the differential on the CBC, which probably, when I was kind of zipping through all the 100 lab points, I was like, I might have missed. So I tried to dictate before the patient's discharge. Not always successful, and and it will cut down on the number of patients you see in a shift. But that was Dan Stillman told me that. It was one of my residency mates back in the day. He said when he started out, he's like, yeah, man, I dictate every patient's chart because it helps me not miss things.
Nice. Thank you.
Yeah, right on. All right. Next question. What did you struggle with most starting after residency? Whew, dude, right there. It's like a 3-day conference. Who asked this question?
That was me. It was a personal question.
Great. Okay. Well, tell me, what is it that you fear? What is the thing that you fear when you were second year or third year that you'd struggle with after residency?
I think for me, transitioning has been, I've always had somebody who's got my back, whether they're fully focused on the patient or not. There's an intern asking me a question, there's a medical student asking me a question, or there's an attending who's going to tell me, hey, don't do that. Transitioning now, I feel like I'm the only one. If you're in a code, you're the only one you're the brain. You need to be the brain. And so being able to step back and say, okay, I'm not doing that intubation. I'm going to trust that my resident's going to do the intubation. I need to be the brain for this code. Or you are the only one that realizes how close you were to somebody decompensating, and thankfully that didn't happen.
Yeah, excellent. Yeah, that's a pretty common fear or a common anxiety, is that all of a sudden the buck is going to stop with you. And that first year out, you have this sense, maybe the first couple years out, have the sense that like, okay, buck's stopping with me. I'm the captain of the ship. And yeah, if I sink, everyone sinks. And I think over time that becomes less and less and less and less, one, because you're more experienced and you're just better at it, right? You just get more experience and you're better. But also you realize that it doesn't all stop with you, because you are, you're asking your students, your nurses, your techs, people to teach you as well and give their input. You don't have to take their input, you don't have to even take the teaching lessons, but they truly do teach you. And so it's like, you kind of think you're an island at first, but then you realize you're really not an island. You're part of the, part of the bigger picture. Now, the flow of the department truly is dependent on your skill of keeping the department flowing. There's no doubt about that. And that is yet another skill. But the things that I've struggled with, or even found surprising, I guess it would be two categories. The first was the money and the business of medicine. And when you're in training, you're idealistic and you're learning to do what's best for the patient. And hopefully everything you do and you think and you learn is all primum non nocere, right? Do no harm. But then you get out and you might be in a group. You go to these group meetings and you'll find that the group meetings, maybe there's like 20 minutes of education, maybe, but it's all about the Benjamins, all about the money, how many patients we see and how many patients you need to see, what's your RVUs, all this stuff. Now, it's kind of exciting in a way because, oh yeah, now I'm making some money. And hey, these guys are on the same page. They're making money too. And it's okay to a point. But then you really got to think about, what are your core principles? And I know a resident, he was a recent grad, and he's in a group that is very focused on money. And they make more money than any group I've ever seen. And this doc had his cases reviewed. And one case I can think of why he was chastised was there was a young patient with right lower quadrant pain, and he got a CBC and an ultrasound. And the ultrasound took a little while. At this hospital, ultrasounds, aren't super quick. And he got really taken to task by the group director saying, you know what, you just need to CT these patients. Just CT them, get them through. And, ultrasound takes too much time. Okay. What's the message there? Is that really what's best for the patient? Has that group director lost his way and shown some poor leadership? For sure. So that sort of thing does happen. And I definitely struggled with that when I first started out. It wasn't immediate, but as I started to see how different groups worked, yeah, that was a challenge. So I think back to one of my mentors, Ken Walker. He was when I was a medical student. He was a program director for 30 years, and he ran the medical school clerkship, and it was all about what's best for the patient. And he had a very high-pitched voice like this. He was from Georgia, and if you didn't do what was best for the patient, let me tell you, he would lacerate you. So, are you doing what's best for the patient? No, you're not. Well then, I don't really care why you're not, because I'm all out of fucks. I don't have one to give. Things like that. All right, kind of a rambling answer. All right, so that was one thing I struggled with. Next was documentation. Documentation. It is such, when you are at a community shop, documentation is your albatross. The EMR, the CPOE is your albatross. You know, if you've got Epic or Meditech or Paragon or, you know, or whatever, or dictation, it's, you know, it's only gotten worse since I started out. And I haven't found that it's not still a struggle this many years out, but developing systems, developing, you know, macros that make sense to me, that I'm, you know, not things like, you know, someone will have a macro for cardioversion, and then they'll have a patient with a code in cardiac arrest, and then they'll put their macro in, they'll talk about consenting the patient and all this kind of thing. Not macros like that, but macros that make sense to you, and templates that shorten the amount of time that you have to be interacting with that. Anything that you can preset that you're, you know, that actually reflects what you're doing, and not just, you know, going through the motions and slapping some nonsense on the page. And then the other thing that I really struggled with when I started out was keeping up with the surges in patient volume. And I remember very well working a night shift, and it was like 3 a.m. and I had, I don't know, 8 or 9 patients, and then 10 patients came in all at once. And it was like the you know, ambulances and all this stuff. I was like, oh my God, what's going in? And I had to call in the other guy who was the morning doc early. And oh, he was pissed. I'll tell you that. But that was really hard, because, you know, as you're saying, the buck stops with you. Yeah, it does. Like when you're by yourself and you get those patients surges, you know, you're responsible for all that. And dealing with that on your own, I found to be super, super challenging. And, you know, I still find big patient surges challenging. But, you know, as you get more experience, you kind of develop systems of, all right, how am I going to deal with all these patients at once? All right, so what was your, see, the original question is what I struggle with. So there's 3 things.
Rob, could you have maybe just 3, 4, maybe 5 specific examples of a chief complaint or a specific etiology that you would use a macro for that's on the safe side? I always find, I think as a resident, in particular the junior residents, it's a little unsafe to just immediately default to macros, because then you're offloading your thinking brain, which is a big part of what residency's for, and being very thorough. For example, chest pain, back pain, are there a couple that you think are worthwhile just as a starting point, and then we can go from there and branch out as we become more senior?
Oh, well, I will say, I think that's a great point, but I personally feel like macros help my thinking brain, because I write them to how I want to think about, let's say, chest pain. So in my macro, I'll have, you know, patient presents with chest pain. Differential diagnosis includes, but is not limited to, blah, 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 blah. You know, ACS, aortic dissection, pericarditis, pneumothorax. And then I'll have a blank that says ED course, and then I enter in the ED course of all the things that happen. And then after that, I have medical decision making. And in my medical decision making has each diagnosis, and then how I actually think about each differential diagnosis. So first thing is, you know, medical decision making, number 1, pericarditis. Pericarditis felt unlikely because X, Y, and Z. You know, symptoms not characteristic, no EKG findings, no physical exam findings. And I read through that. And this is kind of the thing, is I think you need to read through your macro, because it should serve as a check to make sure that you did that and you thought that. And so I'll read through that. And so for pulmonary embolism, you know, pulmonary embolism considered but felt unlikely because, and then I have, you know, you could say PERC negative, right? I have the whole PERC rule written out on my macro. And this is one reason people mess up the PERC rule, is because they don't actually apply the PERC rule right. They don't go through all the things. They say PERC negative. It's like, no, it was PERC positive. So I read through that and say, okay, were all these things on the PERC rule actually negative? And it's like, oh, actually, oxygen saturation was this at one time in their ED visit. I can't use PERC. So, and it goes through all like that. And, you know, it goes through ACS with my medical decision making. And I have a similar one for a typical, not atypical, for a patient's typical headache. If they come in for their typical headache, patient presents with a headache described as XYZ. They state that this is similar to their previous headache, which has been worked up many times in the past with negative results. There are no new characteristics. There are, no signs of meningeal irritation, none of the high risk factors. And I kind of go through that and I read through that, right? That, okay, did this actually happen? Did they actually have a workup? Or is this actually characteristic? Or, oh, wow, maybe it's not. So I use it to, yes, save time, but also to be a hard stop for, make sure I don't miss stuff.
Talking about money and charting and all that good stuff in the community world, I guess Scribes are controversial in there, whether they save time and increase billing or whether they don't. What are your thoughts on Scribes using them or not liking them, choosing not to, how that works?
Thank you for asking that question, man. I about a year and a half ago or 2 years ago, I started using Scribes for the first time and found it to be very frustrating because I was so used to creating the chart that I wanted to create. And think about it, Scribe is usually a college student. They don't have the, now decades of schooling that you have to, well, they've got this, high school, college, et cetera, medical school, residency. And what you're learning there is how to create a narrative. You're essentially, or another way to look at it is you're making an argument for your differential diagnosis. And what a scribe will do will be to collect information, but doesn't put it into the narrative that's in your mind. And might it, throw in some things that are, ooh, that's like a high risk thing you said that could really hang me. Or the patient, it's just like, well, no, they didn't say this way. And what I found was I was going back and spending more time correcting the scribe charts than I was actually due to make my own charts. And I stopped using Scribes for that reason. Whether it led to increased billing or not, I didn't really care. I wanted to have the document that I wanted to have that was a reflection of what I was doing and I felt was medical legally sound. And I just heard of a new method of doing this that if I have access to Scribes again, I will start using Scribes and I will do it this way, is that the scribe oftentimes comes into the room with you and they're kind of typing down stuff. What this particular doc and his group does is the scribe stays outside the room. You go in, you do the history and physical, you come out and you can take a dragon on the scribe's workstation and dragging in the whole history, dragging in the thing. And the thing about dragon is that, it'll convert pelvis to piano, a lot. And so you're dragging it in, they hear it. You can even do your MDM and then they essentially correct it, or you can dictate to them. So they are, really scribing. It's much more clerical and they're not hearing that patient interaction. But when you go in for your next patient encounter, you don't have to wait for the scribe to be complete with X, Y, and Z. You just go zip, zip, zip. Your scribe stays at the central workstation and is working truly on your charts. And, a lot of people love having scribes because it's like, it's having a buddy, you got someone to talk to, someone to teach, and that's totally fun. But I think to truly make the best use of the scribe, that's the best method I've heard of to get the document that you want, to create the narrative that you've worked so hard to learn.
That's a great point. I think that we have scribes in our program and the quality of the notes vary and their thought process varies. So it's a lot more time after the shift redoing a whole chart versus they're ready to sign sometimes, depending on how good they are.
So I'm going to say that scribe idea has changed the way I think about scribes. That I will use them differently. Another thing that I heard recently, this is the white coat investor. Told me this one when we chatted a couple months ago about how his group does night shifts. They do a market-based night shift because you'll go into all sorts of groups where it's like, okay, you're starting this group, you're working all nights until the next guy comes in and takes over your nights. And then what we call that is eating your young. And I have a friend who started in a group where he was like the last guy in, and he's almost 50, and he's still working all nights. And nobody's come in. What his group does and this is totally off the Scribe topic, but just in something that's very clever in how to use something that is common to all of us. They do a market-based night shift system so that, very few people want to work night shifts, but they'll kind of auction them off to say, okay, night shift is now worth X an hour. Who will take it? Night shift is now worth Y an hour. The night shifts go down, night shifts go up, the day shifts go down. And as soon as night shifts are valuable enough to somebody to work nights, then they take it. And then the day shift is paid a little bit less. And so like, all right, granted, it'd be nice if nobody had to work night shifts, but that's just the cost of doing business when you're an ED doc. All right, that's a little bit more than the Scribe question.
Yeah, that was super interesting. You had mentioned something about community medicine. I think you might be talking about this later down the road, but it's something that I'm struggling with right now because, I mean, all of us are going to fellowships or are currently in fellowships or involved in academics in some way, but I'm going to be doing sports medicine fellowship starting August, and then I'm going to start looking for jobs in October. I'm only going to have a couple of months into fellowship before I start looking into jobs. And I'm struggling really hard as to figure out whether or not I belong in the community or in academics, but the more and more I talk with people, it seems that, regardless of whether I go into community or academics, it really depends on my interests. And do you know if picking one versus the other really ends up pushing me down a path, or do I just end up directing myself into what I was meant to go into?
So your first year out, so you guys are all doing fellowships next year. Your first year out of residency or fellowship is your actual fellowship in emergency medicine. And that is when you really learn what it is you like to do. Some people like to see a lot of patients and do all their own procedures. And some people, they just kind of want to teach and have less of that pressure head of, having to do every tiny little task on every patient. There's the upside of community medicine, which is like, you get to do all this stuff. The downside is you have to do all this stuff. And, in academia, you don't get to do all that stuff. You're not doing the intubations and central lines. You're teaching those things. So upsides and downsides to both. But I don't think that you pigeonhole yourself either way, especially when you're fresh out, especially if you're fellowship trained. In the beginning of your career, you figured out you're learning actually how to practice emergency medicine on your own, right? What's it like when the buck stops with you? So I don't know if this is specifically addressing a question, but I don't think you pigeonhole yourself. I mean, I could be wrong, but I don't think that you do, because I know a lot of people who have gone community to academia, academia to community. I mean, especially when you're starting out, that first job you have, highly likely that it's not your last job. And another thing that people don't take into account when they are starting a job, academic or community. So what do people talk about when you're looking for jobs? Like, okay, here's how many patients we see an hour. Here's our acuity. Here's our admit rate. Here's how much you're going to get paid. Here's how many nights we work. Here's how we do all this. What nobody talks about, and it's hard to talk about, is the culture of the group. What is this group of people like? And each group kind of has its own personality. And the thing is that they're all pretty good because we all have this similar mindset, like this emergency medicine mindset. It's like, I really relate to these people. Wherever you go, I really relate to them. But does the culture fit who you want to be, who you are, how you want to practice, how you want to do your sports medicine? It's like, okay, is this a group that says, hey, yeah, have a sports medicine clinic one day a week at the rehab center? If you totally do that. Or no, your job is to do these shifts. Glad you have sports medicine. That's nice and cute, but need to move the meat, suck it up. Kind of an extreme example, but so yeah, nobody talks about culture, and don't worry about finding the magic key, because you're not gonna right away. You might get lucky. Some people just get that first job and it's their whole career. But here's another thing: when you start that job, especially if you start in the community, you will usually, if you're working in a private group, make less than the partners do. There's like the buy-in, the quote unquote buy-in. And I will say this: don't worry so much about kind of what that is, just know that it's a huge scam. It's a huge scam. I have been a partner before, and so I know exactly what this looks like. The only thing that you're buying is things for the partners. You get paid less, they get paid more. And I was in one group where there was a 2-year buy-in, and I was starting out, and the partners made tremendously more than the employees. And I was at a meeting. I was like, what exactly am I buying? And it was like outrage. It was like the papers threw up and all this, because it's just this tradition of, you're working for us for a couple years, and we'll see how you do, but you're going to make less than we do. I'm so opposed to that. I couldn't express it strongly enough. Like, how is the new employee who probably has more debt than you less valuable, because they're probably seeing just as many patients, working the same number of shifts, generating the same RVUs? Yeah, I give that the finger. But just realize that it is the reality. So when you hear that, just know that that's this kind of this dirty, unspoken aspect of private community emergency medicine.
People need pools and Ferraris, It's all about.
Oh, we'll stop there. All right. I don't even remember what the question was, but
no, thank you. That was very useful. I do think that regardless of where we end up, like academic versus community, everyone always says the first job isn't going to be your last job, and it's really all about a learning experience in terms of how to actually practice emergency medicine on your own. So I'm looking forward to it.
Yeah, you know why they say that, Will?
Why is that?
Because it's true.
Because it's true. I thought it was all a lie.
No, man. No, that's what this is. This is like the behind the music episode here. It's the dirty, ugly truth.
I love it.
All right. Let's see.
Hey, Rob, I was hoping we can spend a little bit of time for you to talk about how you are a community medicine physician. Yeah, you have a huge impact on medical education. And it's kind of, it's two completely different pools, and how you ended up doing what you're doing.
Sure. Right. So let me go back in time a little bit to when podcasts first started. I don't even remember when this was, but my brother, Rich, he's an attorney. He was one of the first podcasters way back when. And he had a podcast called Dogma Free America. And it was just about that. It was like pointing out the intrusion of dogma and hypocrisy into our lives. And it was apolitical, but it was also very critical. It wasn't like a lot of positive messages like, hey, this dogma is awesome. We did that together. It was my brother ran the show, and then it was he, I, and another guy. The other guy and I were kind of split off as co-hosts. And during that time, I didn't realize it, but I mean, it was probably like 6 years. I was learning how to do it, like how to write a show, how to talk on the mic, how to do all this stuff. And then as time went on, I was like, this just feels really critical and negative. It was fun to do it with my brother. That's why I like to do it. But I wanted to spread something positive that people could use and not just be pissed off and have outrage. Like essentially like every news show, pissed off and outrage. And so my brother and I'll keep bringing him up. I owe so much to him for like teaching me to do this and motivating me and, definitely mentored me in all of this. So he and I brainstormed for a few weeks about this. I was like, I'm going to do a medical podcast. There was really one, it wasn't even FOMED. It was just one medical podcast out there that was open access. That was EMRAP. And so I listened to it. I was like, oh, this guy's a knucklehead. I could do that. Yeah. I mean, we're good friends now, and it's the podcast I listen to on my way to work. The irony, like I could do that. And little did I know he's a genius, but okay. So I was listening. I was like, all right, I could do a podcast. Now, the show was originally going to be called the Emergency Pediatric Orthopedic Podcast. That was my original idea. Yep, Emergency Pediatric Orthopedics, because my good buddy and neighbor, he was a peds ortho guy, and I figured, you know what, we'll just do this once a week, and I could tap him for knowledge every week and ask him questions. My brother said, that's the dumbest idea I've ever heard. because you're going to limit your content. You're going to limit your audience. Now, granted, the Emergency Medicine Pediatric Orthopedic podcast would be a great podcast. You know, it would actually be great. But there was nothing else out there. It wasn't like I needed to fill a niche. There was just like, it was just, you know, kind of a wasteland, except for a couple things. So we went more general and then had to figure out the first episode. And my first episode was going to be stroke controversies or pediatric limp, right? So really interesting, right? Hey, for us, you know, I see you guys all nodding your heads like, I want to hear about that. And he said, all right, you're an idiot because that does not have a hook. Does not have a hook. So what do people ask you most about at cocktail parties? And that is how the first episode of ERCast became rectal foreign bodies. So that was the start of everything. Now that was all this watershed moment in my career. And I was about 10 years into my practice. I was getting kind of burnt, kind of crispy, working in a super busy community shop, moving the meat. And when this happened, when I did this, I still get chills thinking about it. It was like the sun coming through the clouds. And, you know, I mean, that was 8 years ago, over 8 years ago, and it's still exciting. You know, like, so for example, the other day, I saw that there was this ATLS update and somebody made an infographic on it. I was super excited. I was like, oh my gosh, I want to make a podcast about that. I want to talk to somebody about that. I want to increase my own knowledge and then get it out there and just kind of demystify stuff that confuses us or confuses me, really. I guess that's the audience of one. So that was how things started. And it's interesting when people ask about, you know, well, how do I start a podcast? How do I do this? It's actually not that hard to do to start. I mean, there's definitely technical aspects to make it sound good, but the thing that you need is like, you need drive and passion and to be super interested in the content that you do. Because if you don't, you're just going to be miserable doing it. It's going to feel like work instead of fun. And, you know, and the podcast ain't going to last long. So I can't even remember the original question, but does that begin to answer whatever you asked in the beginning?
Definitely. I love that we started talking about butts and we ended the show talking about butts as well. So it's a full circle.
That's the end. We're going to stop on butts.
Love it. Well, I wanted to thank everybody, especially Rob Orman and all of our chiefs for being here. There's just so many knowledge bombs that went through this hour, but I love talking about, you know, checking your own mental weather map and going home and having some Wheaties and putting on your eye mask to decompress. And so I think you've given us a lot of great knowledge and kind of just thinking about how do we personally reset. And I welcome you guys to our next CRincubator group. All right. Thank you, guys.
Thank you, guys.
Thanks a lot, Rob.